Okay, good day to everyone and welcome to CITYNET Mumbai First webinar series on urban sustainability challenges in post-COVID-19. This is the second of a series of international webinar and today's theme is post-pandemic urban recovery, smart health solutions, Asia perspective. We thank you for joining with us and I look forward to having a productive meeting with you all. And please note that this meeting is recorded and is also being live streamed on CITYNET's Secretariat and Mumbai's First Facebook pages. A post-event story will be featured at both web pages as well. Today's theme is timely and relevant as we race to the finish line for herd immunity against SARS-CoV. Parallel to this effort is the imperative to reflect on the lessons on vaccination and the opportunities gained to better improve urban health in our cities. The webinar is a conversation with experts and health practitioners who have been dealing the challenges and opportunities of urban health. And one opportunity that has stood out is the use of technology for health. This webinar will also seek on further prospects as to how this technology can help strengthen our recovery. Before we go into the dive of our discussion, we are glad to have the presence of our principals from the two organizers who will give us welcome and solidarity messages. We would like to acknowledge first the presence of our CITYNET's Chief Executive Officer, Mr. Yunhong Yim. Mr. Yim has been CITYNET's CEO since January 2020, and he has been responsible for overseeing the institutional and program activities of the network. Before CITYNET, he was Ambassador for International Relations to the Seoul Metropolitan Government for 2 years and a successful Korean diplomat to Europe, among others, Korean Ambassador to Denmark and to Hungary. May we call on Mr. Gyun Hong Kim to do welcome remarks.
Thank you, Polly. Ladies and gentlemen, good afternoon to you all. Welcome to CITYNET and Mumbai First, second part of 3 webinar international series on urban sustainability challenges in the first pandemic world. This time, we will discuss the post-pandemic urban recovery, smart health solutions from Asian perspective. We are glad to have our expert from Mumbai Municipal Corporation, Kuala Lumpur City Hall, and International Vaccine Institute who take their precious time from their schedule to share with us their effort on curbing the COVID-19 cases. They are, for example, to vaccinate as many citizens as possible and to use digital technology to minimize health risks and to ensure better health outcomes to citizens. My special thanks goes to one of CITYNET's associate members, Mumbai First, who helps us organize this timely and relevant webinar. I would also like to note that Mumbai First is supporting our outreach in Mumbai and whole India. But on my part, I would like to take this opportunity to invite our participants from India to join us in the network, which will undoubtedly contribute to recovery and building back better from COVID-19. Well, in the process of our global recovery, we in CITYNET and our member cities commit to strengthen our platform to connect different city leaders and learn best practices from each other. CITYNET has developed necessary tools like the Toolkit on Localization of Best Practices and SDG Navigator to better equip our city leaders in their decision-making process to identify and replicate feasible urban programs for better urban sustainability. I have no doubt that this webinar will contribute to putting forward our hope to recover and heal from the deep impact of COVID-19. We equally hope this webinar will be a mutually beneficial learning experience for us all. Again, thank you and stay healthy.
Okay, thank you, CEO Yu, for the kind remarks.
Thank you, Polly.
Thank you. And we also acknowledge the presence of Mumbai First Vice Chairman, Mr. Ashank Desai. Mr. Ashank Desai is an information technology industrialist and has done a BE from Mumbai University and in graduating year held the second rank in the university. He holds the M Technology degree from the Indian Institute of Technology, Mumbai, and he also holds postgraduate diploma in business management from Indian Institute of Management, Ahmedabad. Mr. Desai is the principal founder and former chairman of Mastech Limited and has more than 4 decades of rich, diverse experience in IT industry. He also guides as a trustee to Mastech Foundation, whose mission is to enable informed giving and responsible receiving. So may we call on Mr. Ashank Desai to do his welcome remarks. Mr. You can unmute yourself.
Sorry, thank you, Polly, for that introduction. So good afternoon to everyone now, even in Mumbai. It is, of course, 1 hour away from good afternoon, but I'm really pleased to be here wearing Mumbai First hat. And before anything else, would like to thank CityNet and Mr. Yim for those kind words to work together with Mumbai First, because this is a challenge which is a global challenge. We all know about it. I don't have to describe it to all of you. But what is required is global response. National response is just not enough. City response is just not enough. We have to understand how globally people have handled the situation and learn from it. So I must thank CityNet for collaborating with us to make this event with Mumbai First. Just as a context, I think Mumbai was one of the most affected COVID city last 1.5 years. But thanks to our municipal commissioners and all other officers, we have been able to contain the impact of that very well. In fact, we have been hearing that City of Mumbai municipality officials are invited to a consult all over India about the kind of management of this whole COVID that they did. But this is not the time to talk about it, but just appreciation for them. Coming back to Mumbai First, a very quick point. You have seen our presentation, but specifically on healthcare, we have been working quite hard before COVID. If we have our other person here, Jagruti, who would remember, we had done a big event in 2009 and produced a report on health for the city of Mumbai, which is still a vision statement and a lot of action orientation. After that, we have done enough in terms of working with MCGM, that is Mumbai Municipal Commission, to work on health issues of poor in terms of diseases like TB, like cholera, which are very affecting poor people. And we had produced a paper which was submitted to state government. And recently we have taken up other issues of healthcare around palliative care and geriatric and psychological support, etc., etc. So this is a part of tradition of Mumbai First to be worried, to be addressing the issues of health in partnership with our partner, which is state government of Maharashtra and MCGM. So we are very, very thankful to them for that support where we can work together with them. Coming back to COVID, just few points. As you know, COVID is a global issue. I hope it doesn't happen for another 100 years, but we should work as if it is going to happen again at any time. And what has made a difference is the response apart from just COVID. I think if you look at a difference between successful countries and those who had suffered, I think apart from being just a population size, which of course makes your numbers look large, but I think one has to really have a response management very well, and that does help very well. So I hope during this deliberation today, we will learn from all of you, all other countries that are participating, to understand how they have handled, and that would be a good input to us. So with those quick remarks on behalf of Mumbai First, I thank all the participants and CityNet and Mr. Yim for participating in this event, and would like to continue this partnership much ahead. Thank you.
Thank you, Mr. Desai, for the kind remarks. And after that, we now go into the heart of today's activity. Let me introduce our expert moderator who will steer our discussion and engage our panelist speakers. Ms. Jagruti Bhatia is our today's moderator. She is a partner with Arca Consultants and ex-director and senior advisor healthcare consulting practice at KPMG India. She had almost 3 decades experience in the healthcare industry and 24 years in consulting. She has been featured in several industry magazines, on radio, television, and has been featured several times amongst the top 10 women healthcare leaders in India. Let us all welcome Mr. Guti Badia and Mr. Guti, if you can take the floor from here on. Thank you.
Thank you so much, Polly. That was a wonderful, introduction, and very thankful to Bombay First as well as CityNet for this lovely international seminar. I think there is a lot of learnings from all sides for us to take. COVID-19, as we know, has shaken up the world. It's a pandemic. I don't need to stress more than that. It has put everything right from economy to healthcare systems to public sector leaders to private sector leaders, everybody to test. And I think the way forward has only been collaborations. The way forward has only been adopting learnings from each other, and trying to constantly change ourselves to fight this pandemic each day. So it has been an uphill task. There has been gray areas. There is nothing right, nothing wrong, because I think everybody just tried to what best knowledge they had. And I'm sure that this seminar will actually lead all of us to understand the learnings from the eminent panelists that we have here. And thanks to both the organizations for making this happen. We also have faced challenges, on healthcare delivery. Healthcare delivery systems had to change. Both private sector and public sector, we had to rethink how we build our institutes. We had to rethink how we operationalize our institutes, how we are actually managing our institutes. Infection control, infection diseases, which was a very small part of organizations, essentially just grew to become a very important division. We had epidemiologists, who needed to be contacted, infectious disease specialists that needed to be contacted, the vaccine manufacturers that we needed to engage with. So, everything that was, not so important, even 2 years ago, suddenly became important. All those things that were high profile suddenly became, a second in priority, and that is why systems changed. I think today's seminar will help us to throw a lot of light on how we need to deal with this further, especially in the large cities. The large cities have huge migratory populations. We have many industries that are co-engaged with each other. Healthcare was always the background of people. If you have a healthy population, you will always have a better economy and a better GDP. And so health was always, even when I was with KPMG, we actually did a seminar with FICCI where we had, said how healthcare is the negative GDP driver. So if you don't have healthy population, then how the GDP can be negatively affected. And I think the pandemic has shown us, more than that. I also am privileged to have with us, Mr. Suresh Kakani, our own additional municipal corporation. Me being a full Mumbaikar, born and brought up here, I'm very proud to, have him
Okay. Mr. Jagruti, you may be, we're experiencing some technical difficulty. Hello, ma'am. Hello. I think there's some technical difficulty now. So, okay, so while waiting for Dr. Jagruti, Dr. Jagruti, are you okay? We can continue. I think there's some technical lapse there.
Pauli,
Okay.
sir, can you hear me?
Yes, we hear you now.
I can't hear you though, and there's some issue, I think.
Let me just check again.
Jagruti, why don't you rejoin?
So I think while waiting for our moderator to,
yeah.
Hello, I am seeing Dr. Jagruti is figuring it already. Hello.
Can you now? Is it okay?
Yes, it's clear now.
Okay.
Okay, you can continue.
Yes. So, did we lose a lot of my part?
Not okay. Exactly.
Sure. So I think with the context being set, and I'm sure that we will have a lot of learnings. I would be presenting something on the private sector and how they have changed and molded in Mumbai city. We also have presentations across, like I mentioned, from our eminent international speakers, Dr. Wartel, as well as Dr. Umi Binti Ahmad, and happy to hear their learnings from Kuala Lumpur City Hall, as well as from the International Vaccine Institute. Vaccination will be, like I said, the driver for achieving herd immunity is what we all scientists hope and to achieve. And our own very own Mr. Suresh Kakani sir, so me Mumbaikar is welcomes you, sir, to share your views, and the wonderful way in which the public sector has really handled, especially the municipal corporation has handled, this pandemic in this mega city of Mumbai. So, let me just before I actually hand over to sir a small introduction of although I know that sir needs no introduction. He is the additional municipal commissioner of Mumbai, and so Kakani sir, over to you, and maybe you can just start the presentation.
Yeah, thank you very much. Dr. Jagruti and the Mumbai First for generous words used for me. So let me take you through the innovative model and we used in Mumbai to handle the pandemic situation. One of the models, successful model is, you can say, the ward war room, which we have used extensively during the first wave and during the second wave as well. Let me introduce myself. I'm Suresh Kakani. I'm IS officer of 2003 batch, and I am now looking after the health portfolio along with other portfolio like solid waste management, fire brigade, and so on. And but it is a challenging situation for us. But I mean, somehow, or with the active support of our team members, of public, we could control the situation. I won't say that we have, eliminate the pandemic situation, but we have controlled the system. As you know, Mumbai is the metropolitan city, and it is one of the biggest metropolitan city, one of the largest urban agglomerations in the world. And if you ask me about the demography of this city, the spread is around 480 square kilometer, The population as per 2011 census is around 12.5 million. But the specialty of this Mumbai being an economic hub, the floating population is also sizable in number, close to 6 million. For a better management of the city has been divided into 24 wards, administrative wards, you can say, and then these wards, 24 wards, are grouped into 7 zones. The population density may be one of the highest in. Can you get to the next slide, please? Yeah, thank you. The population density is one of the highest, approximately 20,000 persons per square kilometer. That may be that is again the challenge for us while dealing with the pandemic situation. Next slide, please. The health portfolio, the health department in Mumbai is taking care of not only providing the healthcare facilities, but also focusing more on the preventive healthcare through community participation, community outreach. We have a strong primary healthcare system, secondary healthcare system, and the tertiary healthcare system. If you ask me about the primary healthcare, we have more than 200 primary health posts, 175 dispensaries to take care of the day-to-day illnesses or the routine illnesses of the persons, 28 maternity homes spread across Mumbai. And all these facilities, primary healthcare is well supported by the medical professionals, medical doctors, paramedic staff. But the most important thing is we have more than 3,500 community health volunteers on our payroll, and they are also helping us to reach out to the people, to make them aware about the illness, to take care of their health, to record their daily vitals like oxygen level or temperature, or to check whether they have got the comorbidity or otherwise. The secondary healthcare, again, we have 16 peripheral hospitals ranging from say 100 beds to 500 beds, and 5 specialty hospitals. You might have heard about the Kasturba Infectious Disease Hospital. But along with the infectious disease, we also have dedicated hospital for TB patients, for the leprosy patients, and along with the other this thing. Probably Mumbai may be having the strongest tertiary healthcare system. We have 5 medical colleges. I don't think, I mean, any other municipal corporation or the urban local body has got the 5 medical colleges under the urban local body. The 5 medical colleges, 4 are the regular medical colleges, and 1 is the dental medical college. But I mean, though we have a strong support, strong network, but we also have the huge private sector. More than 1,400 private nursing homes, hospitals are registered under the Nursing Homes Act. Large number of independent practitioners of various illnesses, and we also have the good presence of the central government run hospitals like railway. We have got the strong presence of railways and the airport, and the naval base is also having the dedicated hospitals to take care of the patients admitted with them. Next slide, please. Just to quickly run through the 10 pillars of Mumbai model, because one of the models is, of course, a war room, but there are the other models as well. Those we have, I mean, used to take care of the patients, to take care of the pandemic situation. Readiness of the system. Though the Mumbai Municipal Corporation has got the strong primary, secondary, and tertiary healthcare, but looking at the volume of the patients, we decided to develop jumbo facilities. And during the first wave, we got 2,800 plus patients at the peak. But subsequently, during the month of June or July, we started getting around 400 to 500 patients per day. But even then, the jumbo facilities having the bedding capacity of 9,000 beds, we decided to continue with this facility, keeping in mind the operational cost and maintenance cost maybe minimum, but without bothering for that, we decided to continue with these facilities. Similarly, the war rooms, I mean, we set up during the first wave in the month of June or July, and then we decided to continue with that thing as well. In between the first and second wave, instead of cutting down or curtailing on the testing facility, We ramped up our facilities, and now we have more than 100 laboratories, either in the public sector or the private sector, to take care of the patients, to test the patients. Initially, we used to test around 20,000. Now that figure has gone up to 50,000, but we are focusing more on the prioritized testing, in the sense the person who is really needing testing, those we are testing. Therefore, our positivity rate initially may be very high, but subsequently it came down very rapidly. We also have enrolled the medical professionals, medical practitioners, by providing the higher pay scales, some incentives, and some security in the form of insurance. The next thing, I mean, we planned the micro planning of the oxygen supply. Everywhere the oxygen supply was in the very short, but the city of Mumbai never faced the shortage of oxygen supply, and especially in the public hospitals. The war room I would elaborate in the subsequent slides. I mean, it was a deliberate decision. It was a deliberate decision on our part that to involve the private sector as well, because looking at the volume of this pandemic, the challenges of this pandemic situation, the private sector initially not willing to join this battle, but subsequently by motivation, by persuasion, they decided to join, and they also played a very good role in taking care of the positive patients. During the second wave, the home isolation facility, which was specially created for housing the positive patient in their home, provided they have got the separate bathrooms and the separate rooms to stay aloof from their family members. We allowed this, and we persuaded them, and we chased them in the sense to know about their health status. We also, with the support of the government, provided some legislative measures to take care of, to support our initiatives, and that also played a very crucial role in regulating or in keeping control of the situation. Exchange of ideas, exchange of information. That is also, we kept all our options, all our channels open, so that the people, either using social media or by using the print or electronic media, we freely shared whatever information we have, be it positive or negative, with the people. And this helped us to increase, to boost the confidence of the common citizens, residents of Mumbai. Now we are using this system for massive vaccine rollout in the public sector and in the private sector as well. Next slide, please. Now, coming back to the war room, which is the main focus of today's discussion, that it is a one-stop solution for COVID-related queries and services that is connected with the citizens, and this is being widely publicized. The major, I mean, if you look at the figure, definitely we are not only chasing the patient, but we are also extending help to the citizen to make them accessible to the testing facility. The home isolation follow-up, because when the patient becomes positive, I mean, if he has got the independent room and the independent bathroom, then home isolation, but not allowing them to home isolation merely on his own. We also, I mean, used to chase these patients from our war room on daily basis, that what is the status of his health, if he requires some admission or what is the status of his oxygen level. The triaging, because so many questions are there, so that also been taken care of by this war room. Ambulance Connect, locating ambulance or finding ambulance to reach out to the facility, medical facility, is again the challenging one during the first few weeks of this pandemic situation in the last year. But I mean, we ramped up our ambulance capacity. Now we have got more than 600 ambulances at our disposal, and that is available free of cost. Bed allotment, the decentralized bed allotment is one of the model which we have used here, and that is also proved to be very successful. And now we are using this model for the vaccine guide, so that the large number of population we have to cover in the minimum possible time. While doing this, the ultimate aim is to reach out to the patient, to shift that patient, to treat that patient, like tracking, testing, and treating. But I mean, this decentralized bed allotment is one of the, I would say, better initiative or the model initiative on our part. This eliminated the delay of the, and ensure the timely admission of the critical patient in the hospital. The ward war room also handled the stress calls, triaging positive patients, guiding citizens for testing and vaccination, arranging bed and ambulances, as I said earlier. And now, I mean, you won't believe, we have received and we have, made approximately 2 million calls in the last 3 months. You can, check the volume of the calls our ward rooms are handling in this pandemic situation. Next slide, please. Decentralized bed management, though it appears to be very easy for us to follow, but I mean, it is backed up with the various initiatives. Like, as I said, we have 100 plus testing laboratories placed at the different locations of Mumbai. Initially, they used to share their positive report with the patients and as per their will with the municipal corporation. So it was really challenging for us to track the patient, to shift the patient to the facility. And because of this, there was used to be a chaos that the beds are not available, though the beds were abundant, but the overall impression was the bed, you may not get beds. And that also causes a mental trauma to the patient and patient's relative. So we mandated to all the testing laboratories that they should share their list once a day before midnight, around before 12 a.m. If you ask me to say so, before 12 a.m. And after receiving that list only once a day, then during the post midnight, our team, dedicated team, used to clean that list. Clean in the sense because this list may be having the patient from the outside Mumbai, which is not in our jurisdiction, residing not only in our jurisdiction. The patients undertaking the test as a follow-up test, or patients maybe from some other part of India. So it was really challenging to clean the list, to segregate this among the 24 wards, because unless otherwise we segregate this, it was difficult for the ward room to track the patient, to contact the patient, and to test the patient whether he is really symptomatic or whether he requires a bed or not. After receiving the bed, we clean the system. Then we share this list with the ward room. Now to tell more about the ward room, because I mean we have set up a ward room. These ward room are run 24/7. Detailed SOPs, standing operating procedures and responsibility of the all ward room officials are put in place, and the proper training has been imparted to them so that everyone should follow the same protocol. These ward rooms are equipped with 30 hunting lines, telephone lines to make or to receive calls, adequately staffed with the telephone operators, with the trained personnel, and moreover, I mean the 10 ambulances per ward room we have deployed, so to take care of, to shift the patient either from his home to facility or from the smaller hospital to the tertiary care hospitals. And each ward room also provided with the 10 medical teams, like community health volunteer, the paramedic staff, and sometimes if doctor's help is required, then doctors. So that in case the patient is unable to share his vitals with us, then we depute, the ward room deputes the team to his house to assess the situation of the patient, condition of the patient, and to further assess whether the patient is, though he is asking for the home isolation, whether the conditions are really suitable for the home isolation, or whether the person is required to be shifted to some facility, either COVID care facility or the tertiary care facility. This ward room has got the coordination with the hospital centers, because I mean the makeshift hospitals, we call it as jumbo center, through the nodal officer at ward room and the field hospitals. These ward rooms are monitored 24/7 by a doctor, by a learned doctor, so that whatever technical queries or the medical related queries received by this room, those can be answered appropriately. All this helped us to build the overall confidence among the population, and overall feeling that yes, Mumbai Municipal Corporation is with us, and there is nothing to worry, nothing to panic. And as and when the beds are required, this will be provided in no time. We also have a tie-up with the private hospitals and the connection with the private hospital as well. After receiving the list at 6 a.m. in the morning, the ward official used to contact the positive patient that yes, you are positive, and share your details with us so that we can arrange bed for you. And this process gets over in three hours time, because during the second wave as well, we got more than 11,500 patients. But even then, our time slot never exceeded the 11 a.m. Timeline for contacting the positive patient. And uh, the second thing we targeted that yes, daily updation of the dashboard. Can you go to the next slide, please? Next slide, please. Yeah. Now, how would the war room official would know that the beds are available in a particular hospital? For that, we have created a dashboard. I mean, having the limited access of the private hospitals, public hospitals, and limited access to the officials. Deliberately, we didn't provide access to the citizens or to the other elected representatives, because providing bed is one of the most challenging thing, and we decided that let us handle it centrally, so that there won't be any chaos at the hospital or at the field level ward rooms, that someone is walking in the hospital and asking for the bed and he's getting admitted, though he is not entitled for that bed. So it was important to allot precious bed to those who need it most. That is what we targeted, and therefore the condition is better in Mumbai. This also reduces, as I said earlier, also the panic leads to the false shortage. I mean, the shortage was not there, but somehow earlier, when the centralized system was in place, so many people were asking for a single bed, and it created a panic among the stakeholders that beds are not available. And I mean, it is difficult for me to get proper treatment. And this reassuring the citizens that yes, it is available and there is no need to worry. The dashboard, as I said, the dashboard has been created on the real-time basis, because as I said, only the limited access was provided to the private hospital, to the public hospital, and to some of the officials. But we ensured that this dashboard should be updated on the real-time basis every after 1 hour or 2 hours. To ensure this, deputed one personnel, one official to each private hospital and each public hospital, because the hospital staff supposed to be involved into the treatment and may not find time to update the system in time. So in order to achieve this, we deputed one personnel per hospital, just to ensure three things: updation of the timely dashboard, how many beds are available, and whether the private hospitals are charging as per the notification issued by Government of Maharashtra, the state government. The war room, this also help us, I mean, the overall bed management in a systematic way. We also have indicated and directed the private hospital not to admit the patients directly. All the patients should be admitted through war room. A single channel should be there, a unified command should be there. There should not be any miscommunication, any misutilization of the system which is available. We have issued a strict guideline to allot beds to only symptomatic and high risk by all public and private hospitals. We also have placed system in place for making suspect beds also available in the hospital. We have appointed auditors to check hospitals for the compliance of orders, because Government of Maharashtra issued various orders for reserving bed, for regulating bed, for charging the patients. To ensure this, I mean, the auditor appointed, and that is also proved to be very helpful for us. The Central Disaster Unit to control and coordinate, because the Mumbai Corporation has got the disaster control room based in the headquarters, and we use this facility for overall coordination, for collection of the information, for sharing of the information, for satisfying the needs or the queries of the persons, of the citizens of Mumbai. Go to next slide, please. This also helps us to reduce panic, and we exchange our ideas, our failures, our successes among the people freely. We kept all our channels open so that there should not be any panic, and the exchange of information uh, would be useful for us to manage the entire situation. Regular messaging by all senior officers to the through social media or through other sources of information or the print media, we used to follow that thing. Feedback mechanism of information sharing was also kept open so that the people should also happily share their feedback with us without fear and without fear. We also developed a habit of updating the media on at regular interval, daily, twice or thrice, depending on the time slots or depending on the situation, and issuance of the press note information facility through social media as well. Next slide, please.
So just a gentle reminder that we have about 4 minutes more.
Yeah, so I won't take more than 2 minutes or 3 minutes.
Thank you so much.
Yeah,
Thanks.
yeah. Said during the pandemic situation, because instead of using the multiple command system, we use the unified command system. A flow of information, flow of directions, flow of this thing, all, I mean, used to be through a single channel. So therefore, that also helped us to increase our efficiency, and all on whosoever on the board are quite clear about what decisions are to be taken, what decisions are to be implemented. We also have empowered our ward officials. We delegated our administrative powers and financial powers to them so that they can decide at the local level freely and without fear and without favor. Of course, this is not the job of the one person or the two person, entire team, because the municipal corporation has got the 40 different departments. But we involve each and every department in this battle so that whatever contribution, whatever the field of expertise, those they have, used to tackle the situation. Involvement of the stakeholders like elected representatives, the NGOs, the other like-minded organizations are also involved at the local level by the ward officials, and the results are now, very encouraging. There was effective coordination and clarity of roles and responsibility of the various teams, because what is to be done by the particular team. Suppose if it is a sanitation team, the role and responsibility has been very clear that the sanitation team should sanitize the community toilets twice a day, thrice a day, depending on the use of those toilets. Then sanitize the small lanes, by lanes, house gullies, and everything. Sanitize the major areas having major footfall. In this fashion, we decided our roles and responsibility very nicely, and those have been implemented. The legislative measures, because it is easier to take decisions, but it is really difficult to implement the decisions. So we developed a system to ensure the implementation of the measures, like ensuring the COVID appropriate behavior. Non-mask users, we have penalized more than 2.7 million population, 2.7 million persons for non-using masks, and we have collected close to 55 crores of rupees in that. Though our aim was not to earn money, but our aim was to ensure the COVID appropriate behavior. Next slide, please. So this is all about my presentation, and thank you for providing this wonderful opportunity to us, to me, to showcase whatever small contribution we have made to the system. Thank you very much.
Thank you so much, sir, for the wonderful presentation, and please do not undermine the role that BMC has played. It is really amazing. Suresh Kakani, sir, and I just a small 2 words about him. Actually, he has finished his MBA, from the University of California in USA, and we were really proud to have him with us. He has also been the Municipal Commissioner of Mira Bhayandar Corporation, Vice Chairman, Managing Director, Maharashtra Airport Development, and Chairman, Managing Director, Mihan. The list can just go on. But I would just like to end by saying he was also the recipient of the Digital India National Award and the Rajiv Gandhi Excellence Award and Indian Council of Agricultural Research Fellowship. So, sir, we were very proud and happy to have you on board with us to share us, your experiences from Mumbai. Thank you so much, sir. We shall move. Thank you, sir. We shall move on to our news to our next speaker, Dr. T. N. Wartel, Deputy General Clinical Deputy General Clinical Assessment and Regulatory Evaluation Unit, International Vaccine Institute. Dr. Wartel has about 20 years of experience in epidemiological studies and clinical research from phase 1 to phase 4 studies and CTD development. She earned her MD in the Paris 12 Medical School, France, and completed the post-graduation diploma in public health from the University of Liverpool. The list is, very, very vast and huge amount of experience, especially in the field of epidemiological and clinical research. She, during her 15-year-old long career with Sanofi Pasteur, before she joined IVI in 2018, at Sanofi Pasteur and IVI during the course of her 15 years. It included clinical research, R&D activities on diseases like Japanese encephalitis, pneumococcal diseases, dengue disease. She also is involved with medical affairs activity at the regional medical experts for Center for Centric, Endemic and Travelers vaccines like rabies, cholera, typhoid fever, hepatitis. We are very proud and happy to have you, ma'am, to guide us through and share your experience with us. Over to you, Dr. Ann Wartel.
Yeah, can you hear me now?
Yes, ma'am.
Yeah, so thank you, Dr. Jagruti, for the introduction. And first of all, I'd like to thank the organizers for this kind invitation for IVI to be present at this important forum. So I would be very glad to present on the global challenges and best practices in vaccination strategies. Can you share my slide, please? Yeah, thank you. So I will try to stick to the timing because there's so much to update you on. So I hope that I can make it in the 20 minutes time frame, and then I would be happy to take questions on. So this is the presentation content with different topics of interest for the forum today. Next slide, please. As we all know, right? Human has experienced several pandemics in its history. It's not the first time we have a pandemic now. And in the past, there have been a flu pandemic, the Spanish flu, and we got HIV/AIDS pandemic, if you recall. And then we now have this SARS-CoV-2 pandemic for a year and a half now, with over 175 million cases and then more than 3.8 million deaths globally. Next slide, please. So I have to say that in the field of vaccines development, it has been very, very rich as far as COVID-19 is concerned, in the sense that we should feel really fortunate to have so many vaccines being developed. If you recall, within a year or so, there have been more than 300 vaccine candidates from 7 different platforms, which is really unprecedented in the field of vaccines development. And we know that we now have 17 vaccines being authorized for use or being licensed with different platforms. It's been a real game changer, I believe, in the field of vaccines and vaccines development. Next slide, please. So as you know, one of the big challenges we had to address previously had been whether we can prove vaccine works in a short time frame, given the global need and given the pandemic. And when you look at the usual pathway for vaccine development, the traditional development, it usually takes 10 to 15 years in normal circumstances, if you will. Now, given the pandemic, and we just witnessed what had happened with COVID-19, is that we were able to accelerate the development of the vaccine and to have a vaccine that is shown to be safe, efficacious within a shortened time frame, which is about a year or so. So which is, again, a scientific breakthrough to me, and that's a really great information we had received since last December. Now, how can we do it? We were able to do it because there were accrued knowledge, information from the past experience with other vaccines and with the SARS-CoV and MERS-CoV vaccines in the past, so we can really leverage the knowledge gained from these vaccines, and then to somehow accelerate the development in the preclinical stage. And there are also ways of accelerating the, I would say, the technical aspect of the vaccine development. If you compress the design, having a phase 1 embedded into a phase 2, then you would gain some time as well to go to the late stage of development with the phase 3. So that is what had been done actually for COVID-19. And of course, we were able to have a tremendous global, to benefit tremendous global mobilization with the regulators as well as the vaccine developers and the research institute to work all together at the same time, focusing on the same topic of interest, which is related to COVID-19 and vaccine development. So all in all, we were able to make it in a short time frame, in a year or so, compared to the normal circumstances or normal or usual time frame. Next slide, please. Now, you have heard about vaccines that have been approved or authorized for use, emergency use context. And I just go through quickly the different vaccines that had been approved or reviewed and approved for use. You have the mRNA vaccine, the very first one approved from BioNTech and Pfizer. And the thing is, I would say a new platform. It has been around for over 20 years now, but it hasn't been approved for use so far. And then with COVID-19, it had been approved for the first time with the mRNA vaccine for COVID-19. Now, one of the challenges that had been shown with the mRNA vaccine at the beginning was I would say, the storage condition, because it has to be stored in a very cold temperature, minus 70 degrees Celsius for BioNTech product and minus 20 for Moderna. And both vaccines should be given in 2-dose regimen, 3 weeks or 4 weeks apart. Now, knowing the constraint with this vaccine, the manufacturers have improved the storage condition. And I just saw the recommendation from Europe saying that the product can be stored in 2 to 8 degrees Celsius in a longer time frame for 31 days instead of 5 days for the unopened frozen vial. So they have improved the storage condition for mRNA vaccine. Next slide, please. So you have also heard about other vaccine platforms that had been approved or for use, the adenovirus vector vaccines and inactivated vaccines. And again, both of them should be given in 2-dose regimen. And you see that all the vaccines have shown a high efficacy. And for some of the vaccines, the vaccine efficacy ranges from 50% up to 95%, so which is really remarkable for novel vaccine to show that it can highly protect against the disease or infection with a good safety profile. Next slide, please. And this one is another one that has been lately shown to be efficacious and also has a good safety profile. This is the protein-based vaccine adjuvanted with it's not alum, it's another alum, MTA alum adjuvant, for this vaccine. The Novavax is a protein-based vaccine that had shown high efficacy. And I just saw lately the confirmation of the efficacy being above 90% for this vaccine. And as I said, some of the vaccine had been developed using the Wuhan strain. And the vaccine had generated data against the Wuhan strain, but also some of the clinical trials have shown good efficacy against the circulating strains in the countries where the clinical trial was conducted. And for this one, the vaccine was shown to be highly efficacious against the UK variant and with a lower efficacy for the South African strain, for instance. So all the vaccines have shown a great protection level as well as a good safety profile. Next slide, please. So I just wanted to emphasize here what matters to people when they go for vaccination. Of course, people want to know whether the vaccine works, whether the vaccine protects against the infection of the disease. And more importantly, the vaccine should also prevent severe form of the disease as well as the hospitalization and death, which is the case from the first vaccine, the first approved vaccines. with Pfizer, Moderna, Sputnik, or Novavax, as well as Johnson & Johnson and AstraZeneca. They all have varying efficacy level, but they all protect against the severe form of the disease, including hospitalization and death. Next slide, please. Now, of course, we are very hopeful to get more and more vaccines, but there's one topic of interest in the scientific community that is related to the variants of concern. And you can see here the 4 variants of concern that have been renamed to be now known under Alpha, Beta, Gamma, and Delta. And why is it of importance? Because, of course, we know from the natural infection that the variants of concern have increased transmissibility, as well as a possible increased risk of hospitalization and mortality with alpha and beta variants, for instance. So it's also a topic of concern for the scientific community. And then subsequently, the question related to the variants of concern circulation is related to the vaccine, because all the vaccine had been designed or developed based on the original strain. And now we have those variants circulating. Whether or not the vaccine protects, that's a question that needs to be addressed. And some of the vaccines that are already authorized protects against the variant of concern with a different level of protection. Next slide, please. Now, I just want to give you the status where we stand in terms of vaccines development. We know that we don't have enough vaccines, even though we have 17 vaccines being used or authorized for emergency use. We don't have enough. We need to have more vaccines being developed and produced subsequently. Here we have seen the first wave of vaccines already approved. And then there is a subsequent wave of vaccine coming up, and all of them are now undergoing the efficacy trial design to show efficacy and also the safety profile of the vaccine. Now, following the first vaccines being authorized, there's a need to do additional clinical trials, and you will see later on in the year, there will be additional clinical trials, much more focusing on the alternative design to compare the investigational product with the authorized vaccine in the targeted countries. So that will be the second wave of vaccine, or second generation of vaccine, if you will, for COVID-19. That will come later in the year in Q3, Q4. Next slide, please. Now, other challenges, global challenges, and you all have heard about the
Dr. Wartel, I'm sorry to listen. We have about another 2 minutes more.
Oh yeah, I will wrap up quickly, but it will be tough. So
No
what is
problem.
important also is the global communication around a risk and a benefit for a vaccine. Of course, as we all know, for a vaccine, there's always some side effect. And there are also some very rare side effects that had been observed actually with one of the vaccines that has been authorized for use. And of course, all in all, at the end of the day, the benefits outweigh the risk for all the vaccines, including the AstraZeneca vaccine. Next slide, please. Now, I just want to emphasize why we need to have more vaccine developers and also those that are quite familiarized with the WHO pre-qualification, because we need to give the vaccine, give its access to a wide population, including low and middle income countries. Next slide, please. Next slide. So there's a way to do that. I will skip this one to show, where the big pharma companies stand compared to the biotech companies. I can skip that one. Next slide, please. Just to say there are ways of increasing the production capabilities is to have some deals between biotech companies and other companies to increase the production capabilities. And it had been done with mRNA vaccine to have the licensing agreement for other companies to manufacture the vaccines. Next slide, please. And in terms of know-how for vaccines compared to drugs, it's very complex process to go through to show the vaccine works and is also efficacious. And I just want to mention here the one from BioNTech that has more than 50,000 steps to go through to have a good safety and efficacy product. Next slide, please. So now, in terms of COVAX facility to ensure a global access to the vaccine, as you have all heard about the COVAX facility, And there, the idea is to provide the vaccine also to low and middle income countries through the COVAX facility. There you have countries that can self-finance, the purchasing of the vaccine, but some of those will be provided with the vaccine through that global network. Next slide, please. So these are the vaccines that had been reviewed by WHO for the EUL, emergency use listing. There are 6 vaccines being reviewed, and one is still pending for the global recommendation. That is the one with the Sinovac, but all the data had been reviewed by WHO for the EUL process. Next slide, please. Now, I just want to give the different vaccination strategy. I use this one from Europe because when you look at across the different regions, the different organizations and countries, they use pretty much the same approach, meaning that they want to prioritize the vaccines to be given first to the high priority groups or high risk group, if you will. But the order of the different high group risk may differ by country or by regions. Saying that we want to target first the elderly population and then go down gradually to a younger population. And that has been done worldwide, I would say. And the only change or difference is between, the ranking of the different groups. Of course, we all know in terms of challenges, there have been the global supply issue. And I just want to end the presentation here with a successful rollout program from Israel. Next slide, please. That's the next one on Israel, to say that Israel has used the Pfizer product. And when you look at the combination of the lockdown, and then they had implemented the vaccination gradually, of course, focusing on the high-risk population, you can see over time that the number of cases has decreased dramatically, and they have now reached more than 60% coverage in Israel. This is a really remarkable vaccination rollout program. I think that's my last slide is related to the summary, given the short time frame I'm given, to say that we are very fortunate to have highly protective vaccines available with good safety profile and a high level of protection. Of course, we need to have more vaccines being developed. And of course, I'm glad to hear that in the meantime, while additional vaccines are being developed, I just learned, from the G7 announcement that they will be sharing more than 800 million doses to ensure we have equitable access to doses, and also for low and middle income countries. I believe that is a great information from the G7 announcement. And lately, I just want to emphasize that even though we have vaccines being authorized already, there's a need to do additional clinical trials and to address all the questions of concern in the community of COVID-19 related to the variants of concern circulating, related to the interchangeability between platforms. Can you receive a second dose with another platform while you had received the first dose with a first one? There's a need to address also the value of the vaccine in pediatric population, and I know that some vaccines can already be given to pediatric population. And we also need to generate additional data to see the value of the vaccine in pregnant and lactating women, in addition to immunocompromised patients. And lastly, I would say that yes, we are all, aiming for having more data on the herd immunity that we are, looking forward to getting it globally. Thank you.
Thank you so much, Dr. Wartel. It was really amazing to hear you, and I wish we could just keep hearing you, because I think this is the main intent of the seminar, is to learn from experiences, and I wish we had slightly more time to, hear out your strategy. But nevertheless, I'm hoping that during the question answer sessions, we will be able to, pick your brains, and I'm hoping you'll be able to guide us through the next points as well. Thank you so much. I now welcome Dr. Umi Binti Ahmed for the next presentation. She is the Director, Health and Environment Department at Kuala Lumpur City Hall. And she's going to guide us through some innovative models that Kuala Lumpur vaccination strategies have done, and what has been the way forward. Just a brief introduction of Dr. Ahmed. She is the Director of Health and Environmental Department City Hall, Kuala Lumpur, has graduated from the National University of Malaysia in 1990. She was honored as the Masters of Public Health in 1999, participated in healthy lifestyle campaign to the Federal Territory community until now. She's been associated with the Federal Territory Malaysia Red Crescent Society in organizing blood donation programs and software also known as AIMS, which provides healthy information on food, beverages, and controlling obesity amongst the City Hall staff. She was in charge of mobile vaccination program for a low-cost housing project in Kuala Lumpur, and she's actively involved in public sanitation at public housing areas for preventive measures in COVID-19. And she was also in charge of dengue control in the Federal Territory of Kuala Lumpur.
CityNet Secretariat, and special thanks to Mr. Yim, CEO of the CityNet, and the rest of the members for organizing this week CityNet Mumbai First webinar regarding post-pandemic urban recovery on smart health solution in Asia perspective. So I'm Dr. Umi Ahmad. I will present the topic about innovative models, Kuala Lumpur vaccination strategies, and way forward. So Malaysia National Vaccination Program for COVID-19 was launched on 24 February 2021, and it's free vaccination for all Malaysian citizens. So the theme for this national program is, in Bahasa Malaysia, we call it Lindung Diri, Lindung Semua, and if we translate in English, means that you protect yourself and protect others. Total population in Malaysia is about 33 millions, and in Kuala Lumpur is about 1.9 millions. We target to achieve 80% of Malaysia populations by February 2020 to be immunized, and hoping by end of 2021, we're able to achieve about 70% of our population. Today, population, and total registration to request is below than 60 years old, and it started from May 2021, and we target to finish by February 2022. And around this phase, probably 40 million of Malaysian population will be immunized. However, we plan to finish earlier by December 2021 by certain initiatives. Okay, these photos show a group of elderly and disabled who are in phase 2 in national vaccination program. Okay. How is the methodology of national vaccination program in Malaysia? So it started with a registration process for everybody who wants to be vaccinated. In Malaysia, we are using a special application which called My Sejahtera X. Just to share with you, My Sejahtera is derived from Bahasa Malaysia words. Sejahtera in English means prosperous. So those who have their own gadgets like handphone, tablets, computer will register themselves through these apps. But those who doesn't have will register through manually, and it is assisted by head of community or any volunteers from non-government organization. For those who, they also can go to the nearest health facility nearby to their home. A request which received by My Sejahtera apps consultant will sort all the application based on their criteria for the appointment of inoculation. Yeah. So the appointment will consist of date, time, location, based on the person address. We are trying our level best to provide them with the nearest facilities. The information will be sent 3 days prior to the date and followed by reminder 1 day prior to the real date. Okay, so next. So this is the frontage of My Sejahtera application. People use it oftenly to scan on a barcode wherever you enter in certain premises, shopping complexes, or buildings. This is to indicate that you are in a certain location based on time and dates. My Sejahtera app is an application developed by the government of Malaysia to assist Ministry of Health in monitoring COVID-19 cases and outbreak. Next. The request to change the appointment date is not encouraged, but if people they still can request if they have a valid reason. Person will be given date for a second shot once completed the first dosage. Once they completed the second dose, a published official certificate will go through the My Sejahtera apps, and simple registration card is also issued, which contains the information on type of vaccines and date of vaccine given. Okay, so this is the pictures to show the virtual certificate where you can trace from My Sejahtera apps. Besides that, you will also be given a card with the information of vaccination. Next. Malaysia government is trying to improve and speed up the inoculation process. Currently in Malaysia, we targeted about 200,000 doses of vaccine per day to inoculate. The national vaccination program in Malaysia are from certain activities like drive-through vaccination center, which already started to operate in several states, but a proper guideline is still needed. And to the update, it is still in a final revision, and I believe it will be there soon, will be practiced soon. The other thing is mobile vaccination units, targeting about 500 old folks home in the whole countries, and it's still going on. And the other thing is mobile vaccination trucks to low-cost housing areas with concentrated population is also ongoing actively now. In the concentrated population, there are probably about 10,000 people living in the same areas. Okay, next. So this is the photos showing drive-through vaccination activity, and currently is practiced in certain location where the individual involved is in a low risk group. Okay, next. And this is our mobile. This kind of truck, there are 4 bays, then we can inoculate 4 persons at once. Okay. Other efforts that we encourage people to vaccinate, there are efforts through the community empowerment programs. All levels of the community and leaders are involved in promoting vaccination and also help in vaccination registration. Currently, there are about 8,500 volunteers. They have already appointed and help us in this activity. We also sending flyers door to door by postage, especially in rural areas. We also collaborate with the business corporation to set up booth for vaccination registration at their outlet. So wherever people go to their shopping complexes, they can register themselves over there. And we also collaborate with local sport marketing as an vaccination ambassadors, and those without internet access can register through manual at health officers, clinics, or hospital. So this photo shows our national gymnast, Miss Farah Ann. She's also holding a placard that she is already vaccinated. Next.
Ma'am, we have about 2-3 minutes more.
Okay.
So,
besides the above 5 efforts, we have other additional moves to encourage public vaccinations. The spouse can request the same date and location with their partner. My Sejahtera app also has a section under dependent registration where family members can assist those who are in needs which not own their own gadgets. And our government has allocated injury fund about 10 million Malaysian ringgit to those who suffered with vaccination complications. And in case the public has missed their appointment, they can inform the State Health Office, State Health Department for reschedule their appointment within 40 days after the first dose. So my last slide will be way forward for Malaysia. So our way forward to improve vaccination program is to target more than 150,000 doses per day, but now is already achieving more than almost 200,000 doses per day. And more drive-through vaccination center, which is still in the guideline reviewing, more mobile truck for vaccination, especially in the concentrated population, a study to make the possibility of making vaccination mandatory, mass vaccination for wet market traders involving 6,000 workers, and also to include children above 12 years in national vaccination program soon, which involve about 3 million of our population. So I would like to say thank you very much for your concentration and support on my presentation. Hope we will have good discussion after this. Bye. Thank you.
Thank you so much, Doctor. It was really lovely to hear you. And like I said, I'm hoping to pick your brains a little bit more during the Q&A section. There are a couple of questions coming in, and we'll hope to be guided by you. Thank you so much. Folly, can we have? I think we can't hear you.
Thank you, Dr. Jakuti. Based on our program, the next is going to be lessons from the private sector.
Yes.
So
can you just put the slides on?
Okay.
Thank you, everybody. And since we have shot out some time, I think I'll just run through some of the slides. Next slide, please. So when we talk about the pandemic and we talk about the industry, I think we need to be aware that this pandemic has affected the entire healthcare industry, the segments being not just healthcare delivery, which we usually land up talking about, but also the pharmaceutical industry, like many of my esteemed speakers have spoken about the vaccine industry, of how diagnostics and laboratories played a major role, medical equipments and supplies to address the oxygen demand which went up suddenly. Medical insurance was also in a state of flux, and they had to also ramp up. E-health, which we've talked about for the last 2-3 decades, but we've not really made headway. Next slide. So in India, the private sector actually although has about only 40% of the beds, but 74% of hospitals, those being in the small and medium category. Even though this is true, almost 70% of the health expenditure is taken by the private sector, either out of pocket or through the private hospitals. Next slide. So what affected post-COVID, and what were some of the challenges that were met by the private sector and how they mitigated that? I'll just quickly run through that. Pre-COVID, we already know that India had a bed deficit of almost 2.57 million additional beds that were required to achieve even a simple target of 2 beds per 1,000 population, and we need almost 3 to 5 lakh beds to be added year on year for the next 3 to 5 years to even meet the current demand. And COVID actually put more pressure on this infrastructure. The public and private enterprises came together to actually build large mega centers to overcome this demand. The pandemic only brought to forefront what we already knew. Next slide. The private sector was, of course, caught unawares and struggled in the initial days. Almost 50% of the beds are in the small and medium category, and hence, it makes difficult for them to survive. But nevertheless, leaps and bounds, the infrastructure went up. Hospitals who had the infrastructure chose to provide COVID and non-COVID treatments separately in separate buildings. Some of them tried to segregate their floors and created separate paths for infectious and non-infectious treatments. This actually helped to manage both COVID and non-COVID treatments and help survival. Diagnostic centers also ramped up their infrastructure and created innovative ways like mobile vans, home healthcare services. This was done both by the private sector as well, the hospitals as well as the diagnostic centers. And Suresh Kakani sir has also explained earlier how the MCGM and government bodies came together to manage this together actually. As we know, based on data, COVID positivity rates remain at 25 to 30% for the 3 to 4 months during any wave, and this actually it presses the need for the ICU beds. We actually needed almost 75,000 ICU beds where patient needed to stay for 5 to 10 days. And this meant that we needed to add almost 5 lakh ICU or oxygenated beds. Both the public and private sector actually did this to ramp it up. Large migratory populations in urban cities also pushes the infrastructure further, and hence futuristic infrastructure needs to be thought of, which needs to be flexible, agile, IT-based, technology futuristic. Next slide, please. The technology, how private sector used technology to help themselves was through Internet of Medical Technology. They quickly went to adopt digitalization, e-health solutions, teleconsultations, home healthcare and remote monitoring for their patients, smart healthcare wearables. All this became came to the forefront. Digital became the new way forward for even traditionally managed healthcare system like ours. Blockchain technology will provide more safe and secure patient data across providers, payers, and policymakers. And this already was explored and needs to be further explored. The role of artificial intelligence and emphasis on centralized research through active public-private partnership, some of my eminent colleagues here, epidemiological data, mining and mapping, and predictive medicine is actually what we feel is the way forward. Next. Integration of health data across private and public sectors, like Kakani sir explained, how patient bed census was managed centrally, mapped, and statistics was mapped, and hence it became easy to manage a relatively large megacity like Mumbai. And if we do this across several cities, it will actually help in predictive medicine and better preparedness for the urban healthcare stakeholders and policymakers. Innovative research is also currently being developed in India. And many of you may know, there is research like medcopters or BVLOS, which is beyond visual line of sight medical drone technologies that is currently being explored. It has already got the DGCA approval, and in Bangalore we have seen one of our most eminent visionaries, Dr. Devi Shetty, is also partnered with that, and trials will be carried on over the next 30 to 35 days. The smaller variants will carry almost 1 kg of medicines across 15 kilometers, and the other can carry almost 2 kgs across 12 kilometers. This is currently already done and got the DGCA approval for trials. Use of robots was done in many places in COVID centers. and also distance healthcare via telemedicine was done. A quick issue of policy changes and ICMR guidelines were issued on 25th March 2020 to mitigate this technology and bring it into the forefront. On manpower and operations, the country already has, a huge amount of deficit. And as we all know, beds do not treat patients. We need to have the right doctors, nurses, paramedics, all to run this entire show. And there are some visionaries who have given several, options like, introducing, the student population who have already finished their final exams, waiting for their results, waiting for their internships. They are qualified. We can probably, help them to help us sail through this crisis, as well as contribute and make them into frontline workers. If and we all know that, if anybody else can, India probably is one of the countries that we can proudly say can produce a few lakh young COVID frontline workers in just a couple of days, and we just have to change a few regulations. Next slide. We all know that almost 2.2 lakh nurses who have finished their GNM, BSc nursing are waiting for their exams can be roped in with incentives. Almost 25,000 doctors who have finished their trainings in medicine and surgery are available. These can be roped in. We have almost 1.3 lakh doctors waiting for their PG seats, from NEET, and there are only 35,000 seats. So we know that almost 1 lakh of them will not or may not be able to make it. These can actually be incentivized, to work in COVID centers and then get grace marks for their needs. This is some of the suggestions has come from visionaries like Dr. Shetty. Operational challenges during SOP, staff motivation, and digitization, mental health preparedness for healthcare workers and stakeholders was also undertaken by the private sector. Amongst the other things that really happened was what we saw a big change in the entire industry was that the private sector, actually the attitude, outlook, and openness to work with different formats came. And I think that we all, being from Asia, we know we have a huge strength in alternative medicine, which we all know is time tested, believed, and is a scientific, a researched system. So we saw a lot of integration across Ayush and allopathy doctors. We actually saw the sector as well as industry moving from treatment to prevention, and introduction of other streams of practices like yoga, pranayam, practices like Agnihotra, which helps reduce atmospheric pollution and creates bacterial and viral loads, which has been proved and tested. Dinacharya, which is prescribed in Ayurveda, homeopathic, prevention clinics all came into the front line and forefront of medicine. And this actually helped holistic medicine, actually helped us to predominantly prevent a lot of cases as well as help the crisis. Hence, we actually the private sector moved from being predominantly tertiary care and understanding the importance of primary and preventive care. Next slide. This is almost my last slide, I think. So community messaging was important. There was a transparent line of communication which became important by the healthcare providers to the community, prepared themselves for the new norm. Home healthcare developed this. They developed it either with their own staff or clinical clinicians and infrastructure, or they tied up with local players. Also, the public sector roped in, and this is how they managed the strike. They also evaluated possibilities like online ordering, post, teleconsult, doorstep drug deliveries, and PPPs also became the norm. PPPs across various interventions, both vertically and horizontally, and a lot can be said, but in this short time, we can only say that a lot of use of CSR funds was done. We have almost 20,000 crores of Indian rupees that are parked on CSR, and these were, efficiently and optimally utilized both by the public sector and given by the private sector. Vaccinations, research, drug delivery, cold chains, logistics, and all this has taken the front seat and will remain so in the next 2 to 3 years till we develop, post-COVID recovery. And thank you so much for a patient hearing, and sorry for rushing it out, because I know that I myself need to have a time check on myself. So thank you so much, everybody. So we will now, move on to some of the questions that have been coming around. And whilst I'll take some of the questions, Polly, Ashwini, I request you all to, also send me out if there are other questions that I may have missed. Can we just start the question answer? Is that good?
Yes, it's good.
Okay, Polly, thank you so much for that. The question, to Dr. Umi Binti or even Dr. Wartel, because this is on vaccination. Any large sample survey done to know the percentage of people for vaccination? And how do we explain people about the adverse impacts of the vaccination? So, Dr. Wartel, if you want to take that. So the question is that how large sample surveys needed to be done, and what is the percentage of people that needs to be vaccinated? Obviously, we know that there is this had to be sped up.
Yes, thank you for the question related to the vaccine hesitancy. I have come across two publications, one large sample size, I would say survey, and one is not that large. So there is one that had been conducted actually in Malaysia, based on 1,400 respondents, and actually in 18 years and above in adult population then, and the overall acceptance rate was high, interestingly, 83%. And actually the lowest rate was 63% in elderly and pensioners population. And the reasons that were mentioned in the surveys, was related to the side effect of the vaccine, the safety profile of the vaccine, and the lack of information, and also effectiveness data and religious reasons. So this is a quite small sample size survey with a high acceptance rate for COVID-19 vaccination. On the other hand, I saw another publication, much larger, with a high rate of COVID-19 vaccine hesitancy, actually. A survey being done on Arabs, and it had been conducted earlier in January this year, based on 36,000 participants from 23 Arab countries and territories. And actually there was a very significant rate of vaccine hesitancy among Arabs in and outside the Arab region. So the reasons that were mentioned in the publication were related again to the side effect communication, the distrust in healthcare policies, or vaccines being expedited in terms of production, or published studies, and also vaccine producing companies. So these are the reasons that were mentioned in that large scale survey publication.
Thank you, Doctor. Dr. Umi Binti, if you can help us and guide us on how has technology actually helped Kuala Lumpur in the vaccine implementation, and how is the city overcoming basically vaccine hesitancy and misinformation that is there? I think, we can actually develop a vaccination strategy for a megacity like Mumbai, listening from you as well.
Okay, thank you, Ms. Jagrati. Of course, yes, true indeed. The technology and modernization is very important to help us in distributing the message and message widely to the public. Furthermore, we need urgent speed to relay the message to the populations. The longer we delay the vaccination achievement, it will give the chance for the virus to mutate and develop resistance to vaccine that we have now. So, as I explained earlier, My Sejahtera X is an application which developed by Malaysian government. It is to assist in monitoring COVID-19 cases and outbreak in our country And second thing, it will empower users to assess their health risk against the COVID-19. Besides that, this application also provide Ministry of Health with the necessary information to plan for early and effective countermeasures. So definitely we have problem with a certain groups of people, especially those who does not own the gadget and those who are staying in remote areas. But for this group of population, we have no choice, only to use manual and old traditional way to register and knowledge distribution. So media electronic is actually essential for all most citizens, and the younger age group hopefully will able to assist their elderly at home and to tap along with this new mode of health service delivery. But to say the importance of technology, our country is intent to use the technology to support better health services. For example, that My Sejahtera apps, within the year, we have updated that from first version to the third version in within a year, and there can be the people can monitor their health status throughout the My Sejahtera in third versions. We also have Doctor On Call. This is a brand from Ministry of Health also, where through this web, people can submit their status, health status. So they will get consultation from the doctors, and if they need further consultation, there's a special link to connect them with the consultant, and they can post the video about what is their problems. And we also have other application, our apps like BookDoc, where public can do pre-booking to the clinic or hospital during this pandemic season, just to reduce the concentration of people in the health facilities. And everybody should scan for their temperature, and we have e-wall system that is early warning alerts and response, where people can be scanned on their temperature, and we can monitor the person movement. So to overcome the hesitancy in vaccine and fighting the misinformation through the vaccination, I think people hesitate because they are due to the fear of the vaccine itself and its side effect, and they are still doubt on the vaccine protection. So it is very important to convince this group of people about the benefit of the vaccines. So in our local study, about 15,000 respondents has been studied, and about 88% of them agreed to get the jab. So during the initial stage of national vaccination program, Ministry of Health has come up with several mode of education and awareness. For example, booklets. Public Health Society in Malaysia also contribute awareness through vaccination benefit. Yeah? InfoVax is a portal about the vaccine news. So this effort hopefully can educate people on its benefits and allay people's anxiety and apprehension towards vaccine. So those who are still hesitate, they are encouraged to get their shot from their personal doctors, where the personal doctors can explain better about this vaccine. Yeah. So okay.
So thank you, Dr. Umi. So over to Dr. Wartel. There is, we want, if you can, throw some light on what have been the success stories and significant, lessons in the current mass vaccination programs that you have implemented.
Well, I have mentioned Israel, right? Because they were the very first country that have started, mass vaccination campaign. And I think it's a combination of different measures. It's not only the vaccination that will make the curve going down. It's a combination of safety measures, lockdown, while deploying the vaccination, in the country. So Israel has been a model in that sense. And you can see now the other countries coming with the same pattern, saying that when you start having 40%, 50% coverage of the population, you start seeing the curve flattened, and then you can control But again, it's we need to maintain all the measures to ensure then we don't have any escape of the effect of the vaccination in the country, having the variants circulating there. So I know that some countries had already issued the guidelines to not wear the mask anymore, to ease all the safety measures, but I would say that we should remain quite vigilant while deploying the vaccination in the country, reaching a certain level of coverage for vaccination, at least 40% or so or more. We still need to keep all the safety measures, social distancing, wearing the mask indoor, for instance. So this kind of thing should remain. Once you have a very stable situation under control, then we can ease the safety measure.
Thank you, Dr. Wartel. So if I think, is Kakani sir there? So there's a question for sir, on how we can institutionalize the decentralized war room approach if for any unforeseen future crisis management. Is sir there, or
Yeah, I mean,
Yes, sir, is there.
yeah. So we have decided to continue with the war room model for the time to come, even if the pandemic situation gets over. And this model we would like to use to reduce the gap between the people and citizens and the authorities, so that in case any health related issues or other any disaster scenario, they can reach out to this war room for getting appropriate intervention or appropriate support during the crisis. This is number one. We are also planning to develop a health plan for each ward, so that a particular ward may be dominated with the particular illnesses, like some ward are having the more cases of tuberculosis, some other ward may be having the more cases of malaria or some other illnesses. So we are in the process of developing the health plan with respect to the each and every ward, so that this war room model can be used to reach out to such patients, and our system or health infrastructure would be augmented on those lines to take care of the local needs. So that is what we are planning to do in the time to come.
Thank you, sir.
Yeah.
Thank you, sir. So while we are on that, if you can also let us know how cities like Mumbai can better manage data across different sectors for better policy planning and implementation.
Yeah, because I mean, we already have a system in place to collect data, because for the COVID scenario, all our data is available, but it is with limited access. It won't be available to the public or to the other organization unless otherwise we tie up with them on the basis of for some research or for some management purpose. Of course, with the NDA, non-disclosure agreement, after signing the non-disclosure agreement. So system is in place, and we also have tied up with IIT and the other school of management to analyze this data, available data, and to suggest what interventions are required, whether any gaps are there in our models, so that we can, in case third wave is there, we can manage the third wave very systematically at the minimum possible time. Yes, data upgradation, data management. This time, I mean, we have from the day one, we are using the IT modules, various IT modules to store the data, to share, to forecasting what would be the number of patients in case the third wave hits us. So everything is being managed, but I mean, we are also tying with some of the NGOs to reach out to the people by using this data, of course, after signing NDA.
So thank you so much, sir. And I think we are almost, going into a time check. We still have just a couple of questions left, and I think we are good to go. Yeah. Doctor. So just one question to all of you, since all of you are here and we have all managed large cities, what are some of the suggestions, and any one of you can actually pick that up, is, for large cities, how do we manage and integrate primary care and prevention, along with along with digital healthcare. So if anybody can take that question.
Yeah, so can I pitch in?
Yes, sir,
Yeah,
of course.
yeah. So basically, we should focus more on the primary health care because prevention is better than cure. If the primary healthcare is strong enough, definitely the future major hazard can be avoided. Major hazard in the sense the major intervention can be avoided. So primary healthcare and the home visit, because the model which we have used here, we are strengthening it further. The home visit by the community health volunteer or the employees of the primary healthcare or any primary healthcare worker to understand what type of illness is prevalent in that area, in that family, in that society, and we can further our interventions in case of need. We have, you might have heard about the My Family, My Responsibility campaign.
Yes.
There we have collected the data of each and every family. It is a very basic data in the sense age group. We can come out with the illnesses which are prevalent in that particular family. Suppose someone may be having the diabetes, or someone may be having the heart-related illness, or someone may be having the kidney-related illness. So all this thing we have collected information, and we are using this data for moving forward. So strengthening the primary healthcare is the need of the time, and we should focus more on that, because that is the only system where we are approaching the patient. It's the patient approaching us. So this really worked by using the same model for the war room, because if suppose I'm approaching a patient that you are tested positive, now you tell me where you would like to go, what your symptoms are, where would you like to be at home, or would you like to be in private facility or the public facility? That really work very well with in the secondary or tertiary healthcare. They wait for the patient to come and then treatment starts. So it is other way around in the primary healthcare. So we should strengthen the primary healthcare. That is what our learning is.
So, and a good PPP project, to rope in all the general practitioner associations and nursing home associations, maybe, that may be like a way forward. And I know data security can be achieved through blockchain, use of blockchain technology and stuff. And I'm sure that, this will help us to pave the way forward. So I think thank you everybody, for this wonderful seminar and wonderful presentation. We know that to just sum up a lot of things that everybody has mentioned. I think Kakani sir's wonderful presentation on the war rooms, and to share with everybody, I was myself a COVID patient, and I was really amazed at the way the corporation and the war rooms have handled this. I was also in a senior advisor with KPMG, and I know that some of the war rooms were also managed by some of the firms. It's an amazing job that was done. Sir, thank you for your insight. Dr. Binti, thank you for also letting us know how we have managed the protect yourself and protect others campaign. I think very similar thing is done across, like Kakani sir mentioned, our family, our responsibility campaign that went on in Mumbai as well. A lot of learnings across, I think, cities, and we can see a lot of similarities as well, so including the vaccination drives, the triaging of patients, having the high risk patients being given first. I think learnings across all the three speakers have been great. We also had a digital platform, and digital certificates were provided even in India, and also mentioned by Dr. Umi. Dr. Wartel also, thank you for your excellent presentation too. And it's interesting to know that there are almost 300 applications in vaccination, trials right now. I think we've not seen this. It has been unprecedented 3 decades of my work in the industry. I think we haven't received so many as much as we have today. And thanks for having shared with us that there are almost 17 vaccines that are already in 3 phases. How does one cut the phases, phase 1 and phase 2, how they can be compressed and be shortened the timelines. So I think very, very interesting, insights from all of you. And I'm sure Bombay First, as well as, CityNet and Mumbai First will be compiling everything together, sending it out to everybody. Thank you so much. And over to Dr. Neville Mehta for our special word of thanks to all the eminent panelists here. We're truly grateful to have all of you on board. Thank you so much. Namaste.
Thank you, Jagruti. You have been really great, and you've done a great job. But before I go into the vote of thanks, just wanted to make a small, just share with you a small information that the first concept of a war room was established by Mumbai First for the city of Mumbai. And that's how the Chief Minister's war room was established. Jagruti, you should be aware of that because you have worked very closely with Mumbai First. And the data that was brought across, and the efficient way the war room has been handled, and been providing service and helping our bureaucrats to actually manage their respective portfolios, has been now accepted as a standard procedure. And that's how you saw so many war rooms coming up, which was established by the municipal corporation. So I would like to very humbly give a little credit to Mumbai First for envisaging this vision many years ago, and setting up this war room and managing it for almost 2 or 3 years with the help of McKinsey. And that was something that we are very, very happy to note that now it's become a norm and a standard procedure. With these words, I would like to thank the CEO of CityNet, Mr. Yim, for spending his valuable time this afternoon in Korea and coming and giving us his welcome on behalf of CityNet. I would also like to thank our very own Mr. Ashang Desai for representing Mumbai First and welcoming all of us. I must also thank Mr. Suresh Kakani, being very, very busy at this point of time. I know how short of time he is, and especially in the mornings when he has to attend so many other meetings and get updates, he has managed to take out some time and be with us and spend the whole afternoon with us. I would like to thank Mr. Kakani for an excellent presentation, and I would like you to convey our greetings and compliments to the Commissioner, Mr. Chahal, and yourself and your team for so efficiently making a difference in the lives of Mumbaikars and making it the Mumbai model, making it a world renowned model where the world wants to know how we handled the Dharavi situation and how we handled the situation in Mumbai, which was so very badly hit. So my compliments to you, and please convey the same to your team, sir. I would like to thank Dr. Wartel. Dr. Wartel, your presentation was excellent. Unfortunately, we were running short of time, but I really wanted to go through certain details that you had on your slides. And I'm sure I'm going to do that when I see the recording and when my friend Polly shares the slides with us. I must also thank Dr. Umi Binti Ahmed for giving us the perspective of the Kuala Lumpur vaccination. I think your numbers speak that you're really successful and you're on the road, and in most of your targets, you're going to reach the targets much before your thing. So thank you for joining us, and thank you for sharing the knowledge. I must thank Jagruti. Jagruti, though you went through your presentation very fast, but it had a lot of matter, it had a lot of depth in it, and you brought out the concept of a public-private partnership. And that is where Mumbai First stands. It is because of these associations like Mumbai First, which is, I think, one of the only associations that I can see in Mumbai at this point of time that is working towards this thing. And in this pandemic, what came out very clearly was how the private sector and the public sector and the citizenship can work together to actually get things done. And what you said, the various achievements, and not only just coming on with your sleeves rolled up on site to help, but also putting the money where your mouth is, and that is through the CSR funds, has shown now that public-private partnership is very, very important, and that all governments all across the world should not neglect the private sector. So thank you, Jagruti, not only for your presentation, but for very, very efficiently moderating and time management of the session. So thank you once again, Jagruti, for coming on board. And ladies and gentlemen, I must thank Polly and his team. Polly has done a wonderful job organizing this whole event, and the platform was flawless. Polly, thank you for all your efforts. It is a pleasure to work with you, and I know this is our second out of the many that we are going to work together. And once again, Polly, thank you, and please convey my compliments to all members of your team who have made this afternoon possible. So thank you, Polly. Ladies and gentlemen, Mumbai First has been in existence for last 25 years. And for last 25 years, we have come out with a lot of innovative measures, a lot of partnerships, and a lot of these panel discussions, which has brought a lot of value, information, knowledge, and technology to Mumbai in particular and India in general. And I must mention here that it was not possible if there was no team in place. So I must bring and compliment my team at Mumbai First, starting with Ashwini Thakur, who was directly working with Polly and was the contact from Mumbai First, which organized this event today. So I must thank Ashwini. Ashwini, thank you for doing a great job as always. Also ably supported by Deepak, Aishwarya Lakshman, Aishwarya Sontake, and Jennifer. So thank you, Mumbai First team, for an excellent job done. And thank you for making me look so good on the screen today afternoon. Polly, I hope I haven't missed out anybody at this point of time, but I must thank the participants. Without the participants, no event is possible. And I must also thank the press who have given us a lot of coverage and spoken about this event, and the participants who have involved themselves, have asked so many questions. I know we can't answer all the questions today, but we will try and get as many answers as we can in a few days from now. I'm sure the presentations will be available on our websites. Please go through it, and if there are any questions, we can always contact the panelists to give you the necessary answers. So once again, thank you for coming on board. Once again, guys, be safe, be healthy, and as we say, health is wealth. So take care of yourselves, and over to Polly.
Thank you, Dr. Mehta, for the general summary. And yes, that wraps our program for today. Thank you again to our esteemed speakers and to our wonderful moderator and to our audience. And we hope you really gained something valuable from this meeting. And as a clean video will be posted on our websites in the next few weeks, along with the presentation from our speakers. And for more information of our programs, you can log on to www.citynet-ap.org and www.mumbaifirst.org. So before we part ways, for our panelists in the meeting room, may I request to turn your video as you take a moment to take a screenshot with all of you who are here in this meeting room. So can we see your photos? And okay, Kevin? Okay, great. So that's it. As what I earlier mentioned at the start of this webinar, this is the second of a three-part series. And we do hope that you join us next time, sometime next month, I think. So on behalf of CityNet, thank you, and please stay safe.
Organizers.
Bye.
Thank you. Thank you.
Yeah, thank you very much.
Thank you.
Yeah.